Welcome to Legends to Leaders. Today we're honored to introduce Kathy Horn. Kathy has spent her career in perioperative services, culminating in supply chain, most recently at Tenet Health, but also at Yavapai Regional in Arizona. Today, Kathy's going to give us a teach on value analysis and OR specialty leads. Kathy, welcome to Legends to Leaders.
Hi, thank you so much, Josiah. I appreciate the opportunity for this.
Well, let's start here. Let's keep it simple. What is value analysis?
Value analysis is looking at what quality product with a financial background, trying to find what is best for a facility. It can be anything from what is recommended from a hospital system, from the corporate level, or from the GPO, which is the General Purchasing Organization. The value is brought together by finding cost savings. This can be done by specialty leads within the hospital. It doesn't have to necessarily be isolated to the operating room. It could be to the cath lab, interventional radiology, nursing. Actually, some of the best savings that I had was from recommendations from the facility itself or even from physicians as well.
So is it that the physicians or the facility itself has access to information about a product, and then they bring that to you in value analysis, and then you do some due diligence? Is that a little bit how the flow of the information goes?
Yes, the request generally comes to me. And once I get that request, then I do work as far as trying to find what is the best pricing available. I start with getting a hold of the manufacturer, find the local representative, and talk to them about potential better increased price points for what they're looking for. And also, when I do that, I look at if the product is approved by the FDA. I look to make sure that it has a 510K and it can be appropriately sold within the US. Then I look at the pricing for that particular product. I validate that it is indeed a product that can be used in the healthcare arena. And then once I do my due diligence, I present it generally to the C-suite and get their local approval, and then that usually goes to corporate.
Better pricing sounds like negotiation.
Absolutely. Negotiation can be done on either point. Some of the facilities, depending on what type of GPO that they're on, could get improved price points because they're of a bigger group. Sometimes if the product that they're requesting for value analysis is not on contract and it does not go against any of the current contracts that we have, that gives myself or someone else in my position able to negotiate improved pricing for that. And you would be surprised that usually the margins that you have that you can negotiate with to get that particular item into the hospital.
Interesting. So if you are a director of surgical services and you want to move into value analysis, or you're a value analysis professional, what are some of the negotiation methodologies or books that you might read that prepare you for a career in value analysis?
There's actually courses that you can take, and there is an association of value analysis professionals that it's called AVAP, and that is very, very helpful. And also, even in AORN, they have modules, financial modules for OR directors. I would highly recommend that for a new OR director to look at the budget process, look at finances, look at negotiating. That can be all addressed if you look for it and are a member within AORN, that you can find those guiding skills to help someone that's new in the perioperative arena. Usually the negotiation maybe started with the OR director, but then it goes to materials management or the supply chain to do the final negotiation. OR directors usually don't have access to every single part of contracting and do not know the behind the scenes of what can or cannot be negotiated or what goes against what the requirements for that particular hospital through their GPO.
Okay, this is fascinating. So, are there examples of products that were brought to you new and you brought them in for presumably the first time use, and then they became propagated throughout the tenant system nationwide?
Not so much nationwide. I've had some products that were brought in for surgical packs. It was kind of interesting with all of the ORs, just for our market here in the state of Arizona, they were still using cloth linen for OR tables. And I had worked with one of the facilities and found out the average of what they were going through per day, plus the fluids in there. And we kind of did like a science project where we weighed the linen before it was used and then after it was used. And then I worked with our environmental services, found out how much we were charging or getting charged per pound for laundry versus using single-use paper for the OR tables. So we ended up changing that for the whole state of Arizona. And actually, in my prior practice, that I hadn't seen actually linen used since probably the late 80s. So this ended up being overall probably within one facility, it was a $30,000 annual savings, and another one I had was 64,000 annual savings by getting rid of the linen cost because you pay per pound.
Wow. Okay, so that's fascinating. Sounds like a fun science
Mhm.
experiment and one that
Mhm.
kind of paid for itself or paid off.
It
Yeah,
did. It was interesting science project, but yet it was cost effective. And not only cost effective for the linen versus paper that we went to, it was also increased turnover time because you didn't have to look for the linen. It came in a pre-packaged set kit, so you could open it up and you would have everything that you would need to turn over the room. And again, the biggest thing, one of the biggest items that the OR looks at, especially a director of surgery, is that they're looking at their turnover time
right.
because the cost is per minute. It can be anywhere from 65 to $100 per minute, depending on the case, for OR time. And if you have a longer turnover time, that interferes with your income for that day for wasted minutes.
Sure, sure. Okay, so the relationship between the value analysis professional and the newly promoted director of surgical services. What are some tips and tricks for having a strong relationship between the two?
Big thing is communication. I have been in several instances where I've had to say no to a director of surgery because they had asked for a particular item, or a surgeon where they get a lot of pressure where they have a new doctor in town. This new doctor wants this new equipment, but come to find out it goes against the current contracting with the hospital system. So I work with the new director and let them know how we can approach the surgeon to say, hey, we just can't do it. Um, that is one big important area for communication as far as new product requests. The other is items that come up for cost savings that either the GPO or the hospital system has found. and they are looking specifically for savings. So it would be like a major turnover, whether it would be like custom packs or something as simple as dressings or tape or IV tubing. I work with the directors of the surgery department and anesthesia and pre-op and post-op and let them know that these conversions are coming. And if it is a highly intuitive product, I make sure that I have the vendors involved with it to do training for not only the director of surgery, but for their staff to make it a successful conversion.
What's the relationship like between the value analysis professional and the GPO?
It is communication with them as well. The GPO usually tells the value analysis team what conversions are coming up. And sometimes contracts are usually like 2 to 3 years. And it may be within that contract cycle that they just started using a product, but then they found better pricing within that. So then the GPO lets the value analysis people know that, yes, we are going to change. And what can you do to precipitate this to make it a peaceful transition from product A to product B, and let the staff know that yes, it is a cost savings. They may be upset about the change, the conversion that they're doing, but in the long run, the money that's saved could be potentially used for other equipment in the long run. But I generally have a monthly, if not bi-monthly meeting with the GPOs to let me know what's going on.
How does the dynamic of the relationship with the value analysis team change from nurse manager of the operating room to director of surgical services?
The nurse manager is usually the one that gets hit the most. The nurse manager is in the forefront. I have been in both positions. So they're the one that hears the doctor or the anesthesiologist disgruntled comments about a particular product or why can't I get this? And the director usually answers to the C-suite and passes that information to the manager to be able to go with the next transition that they're looking at or bring in the new product.
Sure. Is it always a data-driven decision, or is there an element of the squeaky wheel gets the grease?
A little of both. It depends on what the situation is. If the local C-suite is looking specifically for cost savings at that time, they may be a little bit more pushy on the initiative that they're looking at. Just because that they have a squeaky wheel doesn't always mean that they get it. I've seen the difference between profit and not-for-profit hospitals. With profit hospitals, they look mostly at the bottom dollar and they want to be able to keep or try to court a specific surgeon, in this case, to their hospital system. In a broader market, like in Phoenix area where I live, the surgeons have choices. If they're not happy with what they can or cannot get at a different hospital system, they'll apply for privileges elsewhere. In a smaller community-based hospital that may be not for profit, they don't have a place to go. It takes a little bit more for them to leave. And when they have a squeaky wheel and they go to the CFO or the CEO and says, hey, I need this or I'm leaving, they're a little bit more tendency to, okay, let's try to make this successful. Let's see what we can do to make this work, if that makes sense to you.
It sounds stressful, frankly. Go ahead, tell me more.
I was going to say, you can't please everybody all the time. The hard part sometimes can be no. But when you say no, surgeons are data driven. And so are OR directors, or they should be. They have their capital budgets that they usually have to ask for several months in advance. And when a doctor comes aboard and they want to purchase something, if they don't have the capital funds for that, then they have to plead their case to the C-suite and say, what this is what my ROI is going to be, my return on investment. If I get this for this particular surgeon, he will book more cases. He or she will be more present. Sure, it's going to cost us, I'll just throw out a dollar amount, $1 million, but we will get maybe $1.25 million afterwards that we profit after we bring that in. So it's definitely, everything is benchmarking, data driven. You have to have the numbers to be able to get what you're looking for.
So you mentioned it's communication. That's what drives the relationship between the director of surgical services and the value analysis team. How do they interact on a day to day? Is it a cadence of when the team meets, the director makes herself available, or is it a one-on-one in the hallway type of conversation where the relationships really get built?
Sometimes I've had some of my best communication in the hallway, both with the surgeon and the director, because he or she is just running, in 50 different directions, trying to get staffing, trying to make sure she's got her surgery schedule going, and she or he is trying to get the day going. And sometimes that quick minute in the hallway is helpful and beneficial to them. I would recommend, as far as value analysis, that a new director has a routine cadence to meet with the value analysis team. In my position up in Yavapai, I had a monthly cadence where I had the OR specialty leads, the cath lab leads, and the directors there, so we could have one-on-one time and they could present their requests. If it's something urgent, emergent, then communication is the biggest key, where the director needs to get a hold of that person for value analysis and say, I need this particular item tomorrow. Hopefully it's not 4 o'clock in the afternoon and you have to get it for a 7 o'clock case, but it does happen. Communication is definitely the key, because the value analysis person still has to look at what is the cost? Can I get approval from the C-suite, even if it's a one-time approval? Is this product validated through the FDA? Is it safe to use? Can I get the products here? And if it is instrumentation, you need to make sure that you have your sterile processing involved as well. So the key definitely is communication. Value analysis is not a 9 to 5, 5 days a week job. It is 7 days a week, 365 days a year, just like the hospital. Sometimes, emergencies happen. And if you don't have something and you're in a rural area, you can't necessarily borrow something from somebody. You need to get it flown in, and you need to take all that into consideration. So constant communication between value analysis and the OR director is a key element for a successful program.
That's fascinating. I'm going to let you answer the unasked question in a moment. But before I do, what advice would you give to the director of surgical services at the small, rural, understaffed, critical access hospital that maybe doesn't have a strong value analysis presence, and that has to fall to a greater degree on the director herself?
I would recommend that the director has open communication with all of her vendors. She or he will know who they need to get a hold of, and they will be your best line of defense. But again, the vendors are there to make money. So sometimes, they'll take advantage of you, which, obviously isn't the best thing. But bottom line is that you're there for the patient. I would recommend being more involved with AORN, even at the local chapter, because with your peers, you can reach out to them and find out who may be more helpful to you. And also your distributor. Your distributor is on your side, more so, I would say, than the vendor. The distributor will go above and beyond to try to help you find something if it's in their wheelhouse. Um, be open with the surgeons, let them know that you're doing your best to try to get something there, and they're kind of understanding as well. Also, you would be amazed at what you can use in place of versus what you're asking for. Um, Nurses have a pretty good intuition and they can make do with whatever they have on their hands. It may not make the surgeon happy because they don't have exactly the thing that they want, but it will work and it will be for best interest for the patient, for safe patient handling and premium care for your patient.
So I would imagine you mentioned being taken advantage of. So let's expose that risk and explore that a little bit. Agreements, reading agreements, understanding contracts, and how does AI play a role in some of that element of risk avoidance?
I actually just went to two classes at the AORN Expo this year where there was 1,000 nurses from other countries, which I thought was awesome. And there was probably, I would say, maybe 6,500 nurses from the United States. And so it was great to be able to talk to my peers and discuss AI with them. AI will not replace a nurse's judgment. It can offer opinions. You can look at the selection and say yay or nay, but it's never going to replace the skill set that the nurse has. And that's also for decision making. As far as contracting, you have to read between the lines. You have to make sure that you understand everything line by line. Don't just arbitrarily read through a contract and say, oh, I know this vendor, I've used them before, I'm just going to sign. There's always, some gray area that can be put in there, and don't be afraid to redline something and send it back to the vendor to be able to correct it so it's more appropriate for your facility.
That's good advice. That's good advice. What have I not asked, or what advice do you have for the newly promoted director of surgical services?
I would, one thing that we didn't talk about was aligning with corporate culture. Corporate culture depends on what the goals are for that particular facility.
Okay.
I would highly recommend the new director to kind of understand what their touch points are, where they're looking at making money. Whether it is a profit or a not-for-profit hospital, you still need to make money to keep the lights on, pay for your staff, and get your equipment. I would also recommend to maybe look at some bullet points and have strategies to present to the C-suite. Be able to talk the talk with them, see what they want, like a 5-minute drill. This is what I want. This is why I need it. This is the price, and this is the return on investment. That would be a great suggestion for the new OR person. The other thing, once you get some products in, I would make sure that you know about product shortages and product failures and what to do with those. The supply chain, not necessarily value analysis, can be helpful with the new director with that. You need to know what happens if you have a product shortage and what you can use in replace of. Sometimes it's months, especially like through COVID. it was several months before a lot of items had come back. So you need to be resourceful with what you can use. As far as product failures, you need to know what to do as far as, let's say, for instance, a product fails in the middle of surgery. What do you do about that? Obviously, you're going to want to make sure that the patient is taken care of, but then you need to report it to make sure it doesn't happen to anybody else. I would think that that would be important, and you need to know who the key stakeholders are in order to tell about a failure. Value analysis can be very helpful and resourceful. It's great to get your team involved, have OR specialty leads. There's several types of facilities that have ladder programs for nurses where they get an increased wage by being on the nursing ladder, and have that particular person that's interested, let's say for robotics or for pediatric surgery or for open heart surgery, have those leads. They are the people that are in the thick of things and understand the doctor's needs more. Um, uh, New OR director is diversified, but rely on your core staff that's in it every day and understands it more to be resources for you, for the new OR director, so that they can be successful. I've been told that a great leader comes from the people that they support and, get the information from them. A nursing director should not be in a paradigm. They should be open to suggestions, listen to their staff, listen to the reps too. They do know, but you have to know when they're trying to make a sale or whether they're really indeed trying to help your hospital to be successful.
That's fantastic, Kathy. Thank you so much for sharing your insights. Here are some of the favorite things that I heard today. One is the additional resources that we heard about through the Association of Value Analysis Professionals, AVAP, and then also the AORN, which has some ways for you to brush up on whether it's your negotiation skills or generally speaking to become more astute in value analysis. The importance of sending red lines or reading between the lines when you are talking about agreements and protecting against being taken advantage of, and then the structured communication for the director of surgical services in communication to the C-suite. Those are all terrific insights for the newly promoted director of surgical services.
Yes, definitely agree with that. That will help them become more successful in their new career.
Kathy, again, thank you for your insights and value analysis and for your years of service to the perioperative community. You've been a great steward for the value analysis teams. Until next time, this has been Legends to Leaders. Keep up the great work.